Diabetes. Diabetes is a neuroendocrine disorder, most commonly occurring in middle-aged persons due to lack of sufficient insulin produced by the body, or the body's tissues are not sufficiently sensitive to insulin. Insulin is a hormone produced by the pancreas, a 15 centimeter or 6 inches long organ located behind the stomach, embedded horizontally across the abdomen. Pancreas also produces digestive enzymes, lipase to break down dietary fat, protease for protein breakdown to amino acids, and amylase, which breaks down starches into sugars, chemically called monosaccharides, which is used for energy production. Pancreas has two major types of tissues. One, the acini, secreting digestive juices into the intestine, and two, islets of Langerhans, secreting insulin directly into the blood. Dear listeners, by the way, this educational video is made possible by Prescribon, the makers of e-prescription software for digital prescription, available freely for doctors on the website www.prescribon.com. Doctors who are interested in this e-prescription can freely avail of its vast repertoire of more than 100,000 prescriptions. Pancreas has 1 to 2 million islets of Langerhans. Each islet is 0.3 millimeter in size and are close to the capillaries, that is the smallest blood vessel in the body, into which it secretes insulin. The islet contain three major types of cells: alpha, beta, and gamma. The beta cells, constituting about 60% of islet cells, secrete insulin. Historically, insulin has been associated with blood sugar. And true enough, insulin has profound effects on carbohydrate metabolism. Insulin affects fats and protein metabolism almost as much as it affects carbohydrate metabolism. Insulin has been associated with energy abundance. If we take carbohydrates, whether it is wheat or rice, in any form as food, it is digested in the intestine into smaller molecules, chemically known as monosaccharides, mainly glucose, which enters from intestine to blood and is used to meet the energy needs of the body. The quantity of glucose that is not immediately used by the body is stored as glycogen in liver. A maximum of 100 to 120 grams of glycogen can be stored in liver. If there is still excess glucose, then it is converted to fat and stored in fatty tissue throughout the body. All this conversion to glycogen and fat requires insulin. So, excess carbohydrate intake entails demand for more insulin secretion from pancreas. There are two general types of diabetes mellitus. One, type 1 diabetes, also called insulin dependent diabetes mellitus, is caused by lack of insulin secretion. 2. Type 2 diabetes, also called non-insulin dependent diabetes mellitus, is initially caused by decreased sensitivity of target tissues to the metabolic effects of insulin. This reduced sensitivity to insulin is often called insulin resistance. In both types of diabetes mellitus, metabolism of all the main foodstuffs, that is, carbohydrates, fats, and proteins, is altered. The basic effects of insulin deficiency or insulin resistance on glucose metabolism is to prevent the effect, that is, the efficient uptake and utilization of glucose by most cells of the body, except those of the brain. As a result, blood glucose concentration increases. Cell utilization of glucose falls increasingly lower, and utilization of fats and protein increases. Type 1 diabetes, that is, deficiency of insulin production by beta cells of the pancreas. Injury to the beta cells of the pancreas or diseases that impair insulin production can lead to type 1 diabetes. Viral infections or autoimmune disorders, that is, a group of diseases wherein the body, by a faulty mechanism harming its own tissues, may be involved in the destruction of beta cells in many patients with type 1 diabetes. Although heredity also plays a major role in determining the susceptibility of the beta cells to destruction by these insults. The usual onset of type 1 diabetes occurs at about 14 years of age, hence it's often called juvenile diabetes mellitus. However, type 1 diabetes can occur at any age, including adulthood, following disorders that lead to the destruction of pancreatic beta cells. Type 1 diabetes may develop abruptly for a period of a few days or weeks with three principal sequelae. 1. Increased blood glucose levels, increased utilization of fats for energy, and depletion of body's proteins. Approximately 5 to 10% of people with diabetes mellitus have the type 1 form of the disease. Type 2 diabetes, resistance to the metabolic effects of insulin. Type 2 diabetes is far more common than type 1, accounting for about 90 to 95% of all cases of diabetes mellitus. In most cases, the onset of type 2 diabetes occurs after the age of 30, often between the ages of 50 and 60, and the disease develops gradually. Therefore, the syndrome is often referred to as adult onset diabetes. In recent years, however, there has been a steady increase in the number of younger individuals, some younger than 20 years old, with type 2 diabetes. This trend appears to be related mainly to the increasing prevalence of obesity, the most important risk factor for type 2 diabetes in children and adults. Obesity, insulin resistance, and metabolic syndrome usually precede the development of type 2 diabetes. In contrast to type 1 diabetes, type 2 diabetes is associated with increased plasma insulin concentration, that is, hyperinsulinemia. Hyperinsulinemia occurs as a compensatory response by the pancreatic beta cells for insulin resistance, a diminished sensitivity of target tissues to the metabolic effects of insulin. The decrease in insulin sensitivity impairs carbohydrate utilization and storage, raising blood glucose and stimulating a compensatory increase in insulin secretion. The development of insulin resistance in tissue cells, liver, skeletal muscle, and fat tissues, and impaired glucose metabolism is usually a gradual process, occurring over many years, beginning with excess weight gain and obesity. The mechanisms that link obesity with insulin resistance are still uncertain, however. Some studies suggest that obese subjects have fewer insulin receptors, especially in the skeletal muscle, liver, and adipose tissue, than do lean subjects. Impaired insulin signaling inside cells may be closely related to toxic effects of lipid accumulation in tissues such as skeletal muscle and liver as a result of excess weight gain. Insulin resistance is part of a cascade of disorders that is often called the metabolic syndrome. Some of the features of the metabolic syndrome include obesity, especially accumulation of abdominal fat, insulin resistance in the tissues, especially in liver, muscle, and fatty tissue, and 3. Fasting hyperglycemia, 4. Lipid abnormalities such as increased blood triglycerides and decreased blood high density lipoprotein cholesterol, and hypertension. All of the features of the metabolic syndrome are closely related to accumulation of excess adipose tissue in the abdominal cavity around the visceral organs. The role of insulin resistance in contributing to some of the components of the metabolic syndrome is uncertain, although it is clear that insulin resistance is the primary cause of increased blood glucose concentration. A major adverse consequence of the metabolic syndrome is development of cardiovascular disease, including atherosclerosis and injury to various organs throughout the body. Several of the metabolic abnormalities associated with the syndrome increase the risk for cardiovascular disease. Insulin resistance predisposes to the development of type 2 diabetes mellitus, which is also a major cause of cardiovascular disease. Development of type 2 diabetes during prolonged insulin resistance. With prolonged and severe insulin resistance, even the increased levels of insulin are not sufficient to maintain normal glucose regulation. As a result, moderate hyperglycemia occurs after ingestion of carbohydrates in the early stages of the disease. In the later stages of type 2 diabetes, the pancreatic beta cells become exhausted or damaged and are unable to produce enough insulin to prevent more severe hyperglycemia, especially after the person ingests a carbohydrate rich meal. Clinically significant diabetes mellitus never develops in some obese people, even though they have marked insulin resistance and greater than normal increases in blood glucose after a meal. Apparently, the pancreas in these people produces enough insulin to prevent severe abnormalities of glucose metabolism. In other obese people, however, the pancreas gradually becomes exhausted from secreting large amounts of insulin or damaged by factors associated with lipid accumulation in the pancreas, and full-blown diabetes mellitus occurs. Some studies suggest that genetic factors play an important role in determining whether an individual's pancreas can sustain the output of insulin over many years that is necessary to avoid the severe abnormalities of glucose metabolism in type 2 diabetes. In many instances, type 2 diabetes can be effectively treated, at least in the early stages, with 1. Exercise, 2. Calorie restriction, and 3. Weight reduction, and no exogenous administration of insulin is required. Drugs that increase insulin sensitivity, such as thiazolidinediones, drugs that suppress liver glucose production, such as metformin, or drugs that cause additional release of insulin by the pancreas, such as sulfonylureas, may also be used. However, in the later stages of type 2 diabetes, insulin administration is usually required to control plasma glucose levels. Now, let us compare the features of type 1 and type 2 diabetes. In type 1, the age at onset is usually below 20. In type 2, it's usually above 30. In type 1 diabetes, the body seems to be wasted, or it can even be normal. In type 2, there is obesity, especially visceral obesity, that is, the fatty tissues are more inside the abdomen. In type 1, the plasma insulin is low or absent initially. In type 2, it is normal to high initially. In type 1, the plasma glucose is increased. Also in type 2, plasma glucose is increased. In type 1, insulin sensitivity is normal. In type 2, insulin sensitivity is reduced. In type 1, the therapy is usually only insulin. In type 2, there is options of you can have weight loss, and in addition, therapies like thiazolidinediones, metformin, sulfonylureas, and insulin. Fasting blood glucose and insulin levels. The fasting blood glucose level in the early morning is normally 80 to 90 milligram per 100 ml of blood, and 110 milligram per 100 ml is considered to be the upper limit of normal. A fasting blood glucose level above this value often indicates diabetes mellitus, or at least marked insulin resistance. Insulin level in normal persons in milli international units per liter. Fasting insulin is below 25 units. After drinking 75 gram of glucose in 200 ml water, the insulin level 30 minutes after the ingestion of glucose is between 30 and 230. 1 hour after, 18 to 276 milli international units. 2 hours after, it is 16 to 166 units. 3 hours after, it is 25 milli international units. In persons with type 1 diabetes, plasma insulin levels are very low or undetectable during fasting and even after a meal. In persons with type 2 diabetes, plasma insulin concentration may be several fold higher than normal and usually increases to a greater extent after ingestion of a standard glucose load during a glucose tolerance test. Now we will see what is glucose tolerance test. When a normal fasting person ingests 1 gram of glucose per kilogram of body weight, the blood glucose level rises from about 90 mg per 100 ml to 120 to 140 mg per 100 ml and falls back to below normal in about 2 hours. In a person with diabetes, the fasting blood glucose concentration is almost always above 110 mg per 100 ml and often is above 140 mg per 100 ml. After ingestion of glucose, these people exhibit a much greater than normal rise in blood glucose level, sometimes above 200 mg per 100 ml, and the glucose level falls back to the control value only after 4 to 6 hours. Furthermore, it fails to fall below the control level. The slow fall of this curve and its failure to fall below the control level demonstrate that either the normal increase in insulin secretion after glucose ingestion does not occur, or the person has decreased sensitivity to insulin. A diagnosis of diabetes mellitus can usually be established on the basis of such a curve. Type 1 and type 2 diabetes can be distinguished from each other by measurements of plasma insulin. Plasma insulin being low or undetectable in type 1 diabetes and increased in type 2 diabetes. Treatment of diabetes. Recall that type 1 diabetics can produce very little insulin in their pancreas. Effective treatment of type 1 diabetes mellitus requires administration of enough insulin so that the patient will have carbohydrate, fat and protein metabolism that is as normal as possible. Insulin. Insulin is available in several forms. Regular insulin has a duration of action that lasts from 3 to 8 hours. Other forms of insulin, precipitated with zinc or with various protein, usually protamine derivatives to prolong insulin action, are absorbed slowly from the injection site and therefore have effects that last as long as 10 to 48 hours. Ordinarily, a patient with severe type 1 diabetes is given a single dose of one of the longer acting insulins each day to increase overall carbohydrate metabolism throughout the day. Additional quantities of regular insulin are then given during the day at the times when the blood glucose level tends to rise too high, such as at meal times. Until the 1980s, the insulin used for treatment was derived from animal pancreas from cows or pigs. These days, the use of animal insulin has largely been replaced by human insulin. Human insulin is synthesized by recombinant DNA technology in Escherichia coli K12, the common bacterium afflicting the gastrointestinal tract. Recombinant DNA technology, inserting a human insulin producing gene into the genetic material of a common bacteria like E. coli and artificially growing it in a culture medium and harvesting the insulin. Using this technique, it's possible to produce mass quantities of highly purified insulin for the treatment of insulin-dependent diabetics. Human insulins have 4 advantages over highly purified animal insulins. 1. They induce less insulin antibodies, which reduce the efficiency of insulin. 2. Their subcutaneous injection is associated with fewer skin reactions. 3. They are absorbed more rapidly from the injection site. And 4. Less degradation occurs at the site of injection. Human insulin produced by the recombinant DNA process has become more widely used because immunity, that is insulin becoming less effective, and sensitization, that is allergic reaction, against animal insulin develops in some patients, thus limiting its effectiveness. In persons with type 2 diabetes, dieting and exercise are usually recommended in an attempt to induce weight loss and reverse the insulin resistance. In this strategy, if it fails, drugs may be administered to increase insulin sensitivity or to stimulate increased production of insulin by the pancreas, as discussed previously. In many persons, however, exogenous insulin must be used to regulate blood glucose levels. Relation of treatment to arteriosclerosis. Mainly because of the hypertension and high levels of circulating cholesterol and other lipids in diabetic patients, atherosclerosis, arteriosclerosis, severe coronary artery disease, and multiple microcirculatory lesions develop far more easily than in normal people. Atherosclerosis is the buildup of fats, cholesterol, and other substances in and on your artery walls. This buildup is called plaque. The plaque can cause your arteries to narrow, blocking blood flow. The plaque can also burst, leading to a blood clot. Arteriosclerosis is a broader term for the condition in which the arteries narrow and harden, leading to poor circulation of blood throughout the body. Atherosclerosis is a specific kind of arteriosclerosis. Atherosclerosis and arteriosclerosis are often used interchangeably. Coronary artery disease is caused by plaque buildup in the wall of the arteries that supply blood to the heart, called coronary arteries. Plaque is made up of cholesterol deposits. Plaque buildup causes the inside of the arteries to narrow over time. Microcirculatory lesions. These affect small blood vessels, especially in heart, kidneys, that's called nephropathy, blood vessels, eyes, called retinopathy, nerves, they are called neuropathy, and gastrointestinal tract. Indeed, persons who have poorly controlled diabetes throughout childhood, type 1 diabetes, are likely to die of heart disease in early childhood. In the early days of diabetes treatment, the tendency was to severely reduce carbohydrates in the diet to minimize insulin requirements. This approach kept the blood glucose from reaching too high a level and decreased loss of glucose in the urine, but it did not prevent many of the abnormalities of fat metabolism. Consequently, the current tendency is to permit the patient to consume an almost normal carbohydrate diet while administering enough insulin to metabolize the carbohydrates. This approach decreases the rate of fat metabolism and depresses the high level of cholesterol in the blood. Because complications of diabetes such as atherosclerosis, increased susceptibility to infection, diabetic retinopathy, cataracts, hypertension, and chronic renal disease are closely associated with the levels of lipids and glucose in the blood. Most physicians also prescribe lipid-lowering drugs called statins to help prevent these disturbances.